Hello and welcome to another webinar hosted by Radcliffe Cardiology in association with Arrhythmia Electrophysiology Review and Interventional Cardiology Review. I'm Harriet Seeger and I'm delighted to be joined today by Dr. Samir Gafoor, who is going to talk to us about the controversial area of left atrial appendage closure. This disruptive technology allows a way to prevent stroke without blood thinners, but who are the appropriate patients for this? Dr. Gafoor will be looking at current data and different treatment options. Dr. Gafoor, welcome.
Thank you very much for allowing me to be here today. Hello to everyone.
Yeah, thank you for joining us from Seattle. So before we begin, Dr. Gafoor, I'd like to tell our viewers that you'll have the opportunity to ask Dr. Gafoor questions by the text box on your screen throughout the course of the webinar, and Dr. Gafoor will answer as many as possible at the end. So enough from me. I'm now going to hand over to Dr. Gafoor.
Thank you very much, Harriet. And here we go. So the topic of today's talk is LAA Closure in 2015. And the topics that we're going to cover today is what is the risk of stroke and atrial fibrillation, what is the data behind LAA closure, what devices and techniques are available for LAA closure, and what future directions are available for this field. Let's talk about atrial fibrillation. It's known to be the most common cardiac arrhythmia. In the U.S., more than 5 million people are afflicted. More than 5 times the risk of stroke with atrial fibrillation, and more than 90% of clots in non-valvular atrial fibrillation come from the left atrial appendage, and many patients are unwilling or unable to take anticoagulation. What's important to sort of note is this 5 times risk of stroke with atrial fibrillation. Let's look at this by age. So it's one of the most important risk causes of stroke, especially in the elderly, and for patients of certain age groups that had stroke, this was the prevalence of people that had atrial fibrillation. So as a risk factor, it's very highly associated, especially in the old elderly population. Anticoagulation is effective. However, it does not always work in clinical practice, and not with warfarin and not with newer drugs. And let's look into this further. This is a small list, an abbreviated list of the many reasons why somebody would not be on a blood thinner, which is easily available from the packaging from many of these different drugs. But in addition to this, there's also some that come from real-life experience. For example, inadequate laboratory facilities, unsupervised patients, senility, alcoholism, psychosis, et cetera, et cetera. And in addition to this, as we are seeing this from a cardiology perspective, whether in electrophysiology or interventional cardiology, many of these patients are coming in addition to warfarin, being on other blood thinners, for example, clopidogrel, ribothienopyridine, and because of other comorbidities such as coronary artery disease and so on. So this adds to the additional risk from a bleeding perspective, and many of the times these patients often need to have their anticoagulation interrupted for certain procedures. Lone atrial fibrillation, when you put this all together without other risk factors, only about 1/3 of all eligible patients are taking Coumadin, and this actually follows a bell-shaped curve with the different age groups. So if the green is how many patients are on Coumadin, therefore the red here is how many patients are not on Coumadin. You can see how much of a variation there is based on this study from 1996. So looking at this from a CHADS vascular risk score, what certain patients should be on some sort of anticoagulation. There's the CHADS score that's also there, but in addition, the CHADS VAS score has really stepped up the ability for us to be able to identify these patients. And based on the criteria that we have, more than one, according to the European Society guidelines, should be on Coumadin or a new oral anticoagulant. There has also been data that has been shown that patients with even a CHADS VAS score of 1 may have an elevated risk of stroke. Where did thrombi form? And this is an interesting paper based on Blackshear and Odell that was in Annals of Thoracic Surgery in 1996. And they took a look at about 2,000 patients and tried to find patients that had non-valvular atrial fibrillation. At that time, non-valvular atrial fibrillation was defined as patients without mitral stenosis or without, at that time, what was most likely a mechanical heart valve. And so these were patients that had slow flow in the area above the mitral valve. And the question was, where was this often forming? And if you see, in the appendage, this was happening about 90.5% of the time, whereas in the rest of the LA body, it was 9.5% of the time. And this led to the thought that perhaps the left atrial appendage is an important structure for us to be able to not only evaluate, but also potentially treat and exclude to mitigate the risk of stroke. So what is the left atrial appendage? The left atrial appendage, as we know, is an actual appendage that hangs off the left atrium, and it's an area of slower flow in patients with atrial fibrillation. So how do clots form? And part of the anticoagulation coagulation cascade, fibrillation causes blood to stagnate in the left atrial appendage. This becomes an ideal environment for thrombus or blood clot to form. This then dislodges from the LAA and travels through the arterial system, and this then goes to brain, causing restricting blood flow and also causing a stroke. In addition, this can be associated with systemic embolism. And those among us that work on the peripheral artery disease often see these patients that come in with acute legs and acute ischemia. So what can we do for these patients? There are multiple opportunities to be able to anticoagulate these patients. This includes warfarin. This includes a new oral anticoagulant such as Pradaxa, rivaroxaban, apixaban, and more are coming. The question is there a risk, or what is the effectiveness of these medications? So the issues with warfarin are the following: that the warfarin is an effective means of stroke reduction in patients, but can prevent challenges. And we have this amazing range of 2 to 3, which is the therapeutic range, but it's very easy for patients to be outside of this range. And so 44% of bleeding events occur in patients above the therapeutic range, 48% of thromboembolic events occur in patients below the therapeutic range. And warfarin tops the list for emergency hospitalizations and for adverse drug events in older Americans, according to one study. Warfarin also causes bleeding. I remember I just talked about this great range of 2 to 3, but if you look at the risk of intracranial bleeding in red or the risk of ischemic stroke, which is in yellow, you can see the moment that we get outside of the 3.0, you start seeing the risk of intracranial bleeding going up exponentially, and the moment that you get below 2.0, the risk of ischemic stroke goes up even more than that. And so how about these new anticoagulants, which are probably no longer new at this point? They're different mechanisms for us to be able to thin the blood and reduce the risk of stroke. This includes dabigatran, which is an oral direct thrombin inhibitor, or also rivaroxaban, which is also an oral direct 10A inhibitor, and apixaban, which is more of the same. And they have different mechanisms of action, as we can see here, and also different mechanisms of excretion. And so levels have to be adjusted in certain patients, and some are once-a-day drugs, some are twice-a-day drugs, and so on and so forth. But for all of these, according to these trials, the risk of bleeding is increased. And when this is all put together, the risk of bleeding increases anywhere from 2 to 3%, probably a little bit more than 3%. You can see with rivaroxaban, it's coming to about 3.6% in the Rocket AF trial. And so this is an important thing for us to note, is that the risk of bleeding is not decreased. It's roughly similar to where warfarin sits, sometimes a little bit less depending on dabigatran dosing or, for example, apixaban. However, these new anticoagulants have a high discontinuation rate, up to 25%. So that means in a very, very well-controlled, rigorously analyzed, very well-regimented, randomized clinical trial, even in this setting where the follow-ups were very predetermined and very closely monitored, the discontinuation rate was 25%. So 1/4 of patients were not even taking it at the follow-up time period. And so the level of protection is therefore suspect. So what good is a medication when you don't take it? And so that means if at month 1, day 1, the 90-day supply, the pill box looks like this, and then at month 3, day 90, the 90-day supply pill box looks exactly the same. So let's talk about LAA closure, and we'll talk about the different techniques for a little bit, and then we'll talk about some of the data behind this. And for endocardial, there's a vast host of different companies and a vast host of different technologies. We'll focus on 2 of these, and in the epicardial, we'll focus on 1, and we'll talk about what the differences are for these. So what is an endocardial device? This basically is a device that is then placed through a venous approach axis and through a transeptal puncture into the left atrium. And so you can see here, this is an animation showing coming up from the venous side through the transeptal puncture, then going across, and then taking an entry into the left atrium. At this point, the dilator is then removed, and a wire is then advanced into the left upper pulmonary vein. The dilator is then removed, and then this transeptal sheath is then removed. After this point, in this case, this is a Watchman device, so a Watchman sheath is then advanced. a pigtail is then brought into left upper pulmonary vein and then slowly retracted and then brought into left atrial appendage. This is an important point because this is one of the changes in the technique for this that has really changed a lot of the safety issues. And then after this, then the sheath is then brought to the level of the left atrial appendage and the distal component. This is then injected and filled with contrast to get an angiographic view of the left atrial appendage and an areocaudal projection most likely. Measurements are then taken at the distal segment as well as also in the proximal level. And at this point, then the correct device is chosen. This device is then advanced and then slowly unsheathed. And after this is unsheathed, this then makes contact with the left atrial appendage. And so then certain tests are done. Here you can see a tug test being performed to show evaluation of fit. And then after that, angiography can then also be performed to see how much contrast goes around this device. Transesophageal echocardiography is then used as well throughout this procedure to then take a look to see whether there is color flow across this device. After all these criteria are then met, then the device is then, the transeptal sheath is then removed. You can see here a pictorial representation of what happens at 45 days with good anticoagulation, which here endothelialization is present. So let's talk about this device. So this is a Warfarin, the Watchman device is a nitinol structure with the 5 available structures, 21, 24, 27, 30, and 33. These are much more technical components, but maybe interesting to certain people in the audience. So this is 10 fixation anchors around the tissue diameter, which engages with the LAA tissue. The contour shape accommodates most LAA anatomy. Here you have also a fabric cap, which is with a PET membrane, which prevents the emboli from exiting, and this is a 160 micron filter. The St. Jude Amulet device is also an endocardial device, but what's very different about this device is that it has a disc and lobe design, similar to many other implants or devices, but this is specifically designed for the left atrial appendage. The advantages of this is preloaded. This also has a recessed end screw, and these have multiple sizes to accommodate multiple different anatomies. In terms of the devices, in comparison from one to the other, it's too early for us to be able to have a study that really compares them in a randomized fashion, but you can see that there are many different approaches to be able to do this, and some of the different technologies that have come through on this is to really try to find a way to change the anatomical criteria or anatomical limitations of the left atrial appendage by changing the device design to be able to fit the vast majority of anatomies, and that's why you can see some of the different variations. So the data behind the endocardial devices, let's look at this in a little bit of detail. So the Watchman device has a few different studies behind it, as well as the Amulet device also has some studies behind it. So let's look in this a little further. So the PROTECT AF is the classic study that I think everybody in the field should know, whether you're in anticoagulation, stroke, or also in left atrial appendage. And this is a prospective randomized 2-to-1 non-inferiority trial of left atrial appendage closure versus warfarin in non-valvular AFib patients for prevention of stroke. And the primary endpoints were efficacy, which was stroke, CV death, or systemic embolization, or safety, major bleeding device embolization, or pericardial effusion. And this was using CHADS 2-score. Mean was 2.2, and key inclusion criteria was CHADS more than 1, eligible for long-term warfarin therapy with any stage of atrial fibrillation. And the follow-up was for 45 months, and they had 59 sites in the U.S. and Europe with enrollment over this slightly more than 3-year period. And so when all this was put together, if you can see the number of patients in this 2-to-1 strategy, if you look at the bottom left, the 463 patients were randomized to device, 244 to warfarin. If you look at this from an efficacy endpoint that we just described, there were significantly more events in the control group, and Watchman was found to be superior to warfarin at a 60-month or 5-year time frame, when this was found to be statistically significant. From a safety standpoint, this is a very interesting graph because it shows that at the very beginning, you can see the amount of safety endpoint events, and you can see this patients in the device arm have many events at the very beginning, which is very typical for any device versus drug study. And then you can see at the 5-year mark how the device and warfarin arms have really come closer together, and this is a non-significant difference, and Watchman is found to be non-inferior to warfarin. What you can see here is that this really shows that life expectancy of the patients should be taken into account when comparing this to anticoagulation strategy. And so that's one of the things that, as we think about patient inclusion and the correct patients, an important point that I personally take in my practice. If you look at the individual endpoints, ischemic stroke, there was no difference between device and warfarin at this time period. For cardiovascular mortality, there was a difference between device and warfarin. And for all-cause mortality, there was a difference between the Watchman device and warfarin. And this really speaks to the impact that bleeding really has for these patients and how detrimental it is to have these bleeding events with warfarin is what my take-home, what my takeaway point from this study was. So what next after this big study? And I sort of cheated and showed you the 5-year data on this. But when this study first came out, there were a few issues that people had with this study. One was that this took low-risk patients. 34% of these patients had a CHADS-2 risk score of 1. Many practitioners would really doubt whether these patients were really anticoagulation candidates, number one. Number two, adjunctive antiplatelet therapy patients with aspirin and clopidogrel were enrolled, and then 56% of the patients had safety events on day of the procedure. And so this was something that was really challenged by multiple critics in terms of the study. And this was therefore followed by a continued access registry, which was a non-randomized registry, and 460 patients at 26 centers after the study had been complete, after the PROTECT AF study had been completed. So what did we learn from this CAP, or Continued Access Protocol Registry? So this CAP registry showed an improvement in the learning curve. And what you can see is that the serious pericardial effusion risk is now down to 2.2%. There were no procedure-related events, and the risk reduction was 56% in this procedure or device-related safety events. What you can see here is that if you divide it into 3 groups, PROTECT AF early, PROTECT AF late, and then the Continued Access Protocol, you can see that all of these events have now decreased over time. And this was one of the really big take-home points from this study that really showed that there was a learning curve to this, and that things got better with the experience. And that is very common for device studies and different techniques, but I think this was one of the places in which this was very elegantly shown. So according to the U.S. FDA, this was still not enough, and therefore another trial was mandated, or basically recommended and therefore done. This was a prospective multicenter 2-to-1 RCT, and they wanted new implanters to be involved. And at this point, CHADS-2 was supposed to be 2, or CHADS-2 was 1 if certain criteria were met, which you can see here. When they had different primary endpoints, and the first endpoint was the same, but the second endpoint was 7 days post-randomization for ischemic stroke and systemic embolization. From this trial, what did this show? This showed 461 patients enrolled, 407 randomized. There were more patients were older, more patients were diabetic, more patients had stroke or TIA. Implant success now improved to 95%. Vascular complications now were 4.4%. Tamponade with pericardiocentesis was now down to 1.5%. Tamponade with requiring surgical repair was now down to 0.4%. So we've shown that this, even with new implanters, still has a decrease in the learning curve, a decrease in events, which basically shows how communication with other implanters and how the experience learned from one implanter or one site, when shared, can also decrease the overall events across the board. In addition, one of the biggest take-home points from the PREVAIL trial was the ability to discontinue warfarin. So according to this trial, the way that the PROTECT AF trial was set up was that the patients were required to be on, candidates for warfarin at the beginning of the enrollment. They then received the device. They were then placed on warfarin for 45 days. At the end of 45 days, they were then evaluated with a transesophageal echocardiogram. If there was a significant leak, which we can go into it during the question period, or there was a thrombus, then they were then continued on warfarin. Otherwise, they were able to discontinue warfarin. And if there was a thrombus, they would then watch it for another 3 months, and then potentially take after another TE, take the patient off if it was felt that the thrombus was then gone. And you can see at 45 days and at 6 months, with the bottom, you see the PROTECT AF. The rate of warfarin discontinuation is 86.8%. At 6 months, it was 92.2%. At 1 year, it was increased from that. But in the PREVAIL subjects, 45 days post-implant, this was 92.3%, and 6 months was 98.3%. So potentially, there's not only also a decrease in the safety events, but also potentially an increase in efficacy with an ability to discontinue warfarin by the by the physician, and this could be twofold. One, because the patients were also better served by the procedure in terms of technical success, but also twofold in the sense that physicians were able to learn from each other as far as what patients they felt comfortable taking off of warfarin and how. So after this, a patient-level meta-analysis was also performed looking at all of these patients together, and this was 2406 patients over 5931 patient years, and this was published this year with a mean follow-up of 2.69 years. And so there was less, Watchman had less hemorrhagic CVA, fewer CV unexplained death, and less non-procedural bleeding compared to warfarin. So another endocardial device we talked about was the Amulet device. The earlier generation of this was the ACP device, and this was a very impressive study that was took a lot of work to really put together, and we were glad to also be a part of this study as well, which was the study by Sikas et al., which is 1,047 patients over 1,345 follow-up years, and this was 22 sites. Enrollment was from December 2008 to November 2013. Age was an average of 75. CHADS-VASc score average was 4.5. CHADS-2 of 2.8. And then the implant results for this showed a 97.3% successful implant rate, and in 93.3% the first device selected was implanted. And what the point that's being made there was that sometimes the correct device size is not chosen because the fit was not correct, and therefore a different size may have been chosen. This is showing that across this real-world registry, 93.3% of the time, the first device that was selected was a device implanted, showing that the pre-procedural and periprocedural imaging had really come pretty far at this time. Access transeptal puncture was used for the vast majority of patients, and then you also see a very interesting table here, which is showing combined procedures, showing the facility and ability of the implanting physicians to also feel that they could feel comfortable doing other procedures during a similar setting. One interesting one, for example, is PCI, in which these patients may be on aspirin and clopidogrel, or aspirin and thienopyridine after this procedure, and you could see why it would be very important for these patients to be off of anticoagulation to avoid triple therapy and an increased bleeding risk that provides. In addition, you could see some providers also doing TAVI and so on and so forth. 7-day periprocedural complications, and this was the exact same as the PROTECT AF endpoint. And here what was seen was that death was 0.76%, pericardial tamponade was 1.24%, major bleeding 1.24%, and total was 4.3% at this point. And you can see some of these complications being listed out as to what the deaths were here. Also a high closure rate at follow-up, and so at follow-up you can see it was 98.1% is what was reached, and the median was at 5 months for this real-world study for the data that we had, and this was of course seen in only 632 of the 1,001 patients because this was the data that was then submitted, so there is an asterisk for this data point here. This showed a reduction in stroke and bleeding, and so you can see based on CHADS-VASc score what the estimated risk of stroke was, which was 5.62%, and the actual risk of stroke here was 2.3%. The effectiveness in bleeding from a has-bled score, which is a risk score for bleeding that is often used in the LAA literature. This is 5.34%, and according to the observed rate in this study, which was only 2.08%, that gives us a 61% risk of reduction for bleeding in this study. So we've covered some of the data behind endocardial devices, and although there are many, many others listed, the Plato device is actually out of production at this point. Coherix is putting together the data and should be presented in upcoming conferences and so on, and other devices are coming forward, and LifeTech has also finished their study as well. Let's move on over to the epicardial devices. So of these, we'll pick the Santo Heart device to talk about this. And what's interesting about this is that this is an epicardial approach, so it uses pericardial access to then approach and then ligate the left atrial appendage. So what we see here, this is an animation of this. Here a transeptal approach is then done, and then a magnet is then placed at the distal part of the left atrial appendage. A balloon is then used to fixate this magnet in place without requiring excessive manipulation in this very fragile structure. After this point, pericardial access that has already been obtained, a magnet is then brought up from this side, and this magnet-magnet interaction makes a rail over which a lasso, which is a Lariat device, is then advanced and then brought up over the left atrial appendage. This is then brought to the proximal part of the left atrial appendage, and then at this point then closed down after the balloon is put up. And so at this point then what happens is that we've achieved a pretty good seal at this point from a technical perspective. The balloon is then withdrawn, the magnet is then removed, and the suture is then closed even further at this point, and then this gives us a seal. When the attractive point about this is that there is no device that is in contact with blood left behind at this point. Here is a suture cutter coming to cut the suture, and this part is all that is left behind in the pericardium at this point. So a very attractive option. What is the data behind this is important for us to review. And here's another point as to kind of how it looks on fluoroscopy as well as in transesophageal echocardiography. So the data behind this, there are multiple studies that have been done, kind of looking at this from a cumulative perspective of 280 patients for this, which was intent to treat was 269, 96% were treated, 98% procedural closure. 60-day closure with TE was seen in 91% of these patients. And of these, all all-cause mortality was 3.2%, 2.6% risk of stroke, risk of bleeding is 1.1%, pericardial effusion is 2.6%, and for these, pericardial effusion is a different entity because of the pericardial access that's obtained as well as the drain that's left in place. And so this potentially has a different definition set, but that's another point for us to talk about at the very near the end of the talk. Here's an interesting paper that was written by Srivastava et al. Talking about the overall Lariat data. And if you see here, their evaluation has 334 patients. And from this, what they took away from it is that the device success is 94%, durability is high at 98%. Procedural adverse events is listed at 14.7%. And from the a lot of talk this year has been about the MAUDE database and the risk of events that have been shown. Here you can see the risk of death from this is 0.3%, and the risk of LAA laceration is 1.8%. What's important to see is that the procedural adverse event rate is really driven a lot by significant pericardial effusion. And this is requiring pericardiocentesis or vasopressor therapy. And in addition to this, pericarditis is a significant entity. Late adverse events was 9.9%, and this is driven also by pericardial effusion. And that's another point that's still important for us to be able to discuss. What's important here to note is that there are two or three events that have, for two or three important points. One is that the Lariat device has also changed from the time that many of these studies were done. The device size has also increased from 40 to 45 millimeters, making this able to maneuver, as well as the braiding on this device has been able to be able to maneuver over the left atrial appendage, number one. Number two, just like anything else with device and learning curve, there is a learning curve for pericardial access. Pericardial access, in my opinion, is something that is very, very rarely done unless done by an implanter that has significant experience with epicardial ablation, and therefore is getting pericardial access for that. And that takes its own time, and that has also been improved by different needle and technical improvements from the access standpoint. However, this is still something that we'll need to monitor closely. In addition to this, colchicine has been given to decrease the risk of pericarditis. One important point is that even though there is no material left behind that's in contact with blood, there still have been leaks that have been shown with this device due to incomplete closure, number one. And number two, this does show that there still can be thrombus that's associated with this. So the ability to walk away from a Lariat without using any anticoagulation is not a risk-free proposition. So the indications in correct patients, I'm going to bring up the FDA approval. I know many of, and I'll bring up also the European perspective on this because it brings for a very interesting conversation. So the FDA approval for this device has been for non-valvular atrial fibrillation, increased risk for stroke and systemic embolism based on CHADS-2 and CHADS-2 VAS score, and deemed by physicians to be bold points suitable for warfarin, and have an appropriate rationale to seek a non-pharmacologic alternative to warfarin. So this is what the FDA approval is based on the PROTECT-AF study, as well as the other studies that have been proposed by Boston Scientific in regards to their Watchman device, which is the only device that's available now in the United States at this time. However, there's a slight intercontinental difference, and if you can see in the 2012 focus update of the ESC guidelines on the management of atrial fibrillation, there is a management standpoint for atrial fibrillation in terms of valvular AF. This should go to vitamin K anticoagulants and so on, but non-valvular AF, if it is less than 65 years, and lone AF, including females, there was no antithrombotic therapy. After that, CHADS-VASc score was then evaluated. CHADS-VASc of 1 and onward was given to oral anticoagulant therapy, and a bleeding risk was therefore supposed to be assessed, including has bled. And an important point here is in the guidelines, the patient values and preferences were also an important part of this guideline diagram. So what was recommended at that point in 2012, this was a 2B level, 2B class recommendation in patients with a high stroke risk and contraindications for long-term oral anticoagulation. And so this became now a very big difference in terms of where the FDA is standing as well as where the European guidelines are standing. And it goes through the different mechanisms as to how these were approved in the different countries and so on. So in Europe, the first LAA occlusion was with the Plato device was done in the early 2000s at the Cardiovascular Center Frankfurt with the Plato device, which is over at the top left. And you can see the vast host of devices that have been used in Europe, from the Watchman device, the St. Jude device, Amulet device, Coherix device, Lariat device, and so on and so forth. And so the institutional experience is much larger, number one. Number two is that these devices, for the most part, in registries and so on, were really focused on those patients that were not doing well on their anticoagulation strategy. And that's, for the most part, where this organically grew in the European market. And more studies and more registry points, in addition to the one that I showed you from the 1,000-patient study. This is a nice list of studies that was listed in a paper that was done by Lopez Minguez in Heart in 2015, and he looks at about 549 patients that were all done with people that were contraindicated for oral anticoagulation. And the CHADS-VASc score here is 4.2, follow-up was 20.38 months, and at this point, stroke risk was down to 1.28% versus a projected of 7.25%, and therefore this was a different strategy and so on and so forth. You can also see here why the anticoagulation strategy after the device was placed or the LAA was ligated was very different. Here, aspirin and thienopyridine or DAP dual antiplatelet strategy was more often used because these patients were not candidates for anticoagulation. Watchman has also done this in the European market, and so this was a ASAP trial, which was aspirin and Plavix only. And so these are patients with Watchman that had only aspirin and Plavix that were used. And you can see procedure and device-related serious adverse events. There were 8.7% had procedure and device-related SAEs, but very few had any femoral pseudoaneurysm or femoral hematomas. And you can see the clinical outcome. And what's important here is that the expected rate with CHADS-2 was 7.3%. The expected rate, if used aspirin and clopidogrel alone without any device in place, would have dropped that down to 5.0%, which is a very important statistical point that they brought. But here, compared to that, even then, Watchman, followed by aspirin and Plavix, really gave an actual seen rate of ischemic stroke of 1.7%. So how do we put this all together? And I think this is a very elegant paper written by Bernie Meyer and Horst Siebert and others, and that was presented in Neurointervention. And so what this was done is really look at CHADS-VASc patients more than once, and starting from there, and figuring out, okay, if they were suitable for oral anticoagulation, then, which is on the left-hand side, these were preferable for new oral anticoagulation, and LAA occlusion should be mentioned. If they were at increased risk for bleeding, and at this point this is defined as has-bled score of 3 or more, or they needed prolonged triple anticoagulation therapy because of recent stents, or increased bleeding risk was not reflected by the has-bled score because of tumor, thrombocytopenia, cancer, or other reason, or renal failure that made them a contraindication to new oral anticoagulant, then that was then an individual risk-benefit evaluation. And if they were acceptable risk for systemic new oral anticoagulation or oral anticoagulation, then LAA should be mentioned. But if they were not, then no treatment versus LAA occlusion. A third category also existed, and this is real life. patient refusal of oral anticoagulation despite adequate information. This is where they were supposed to advise into oral anticoagulation, but otherwise LAA occlusion. But then they should also know that there was a need for antiplatelet therapy afterward. And at this point, this also includes the last category, which was contraindication for systemic anticoagulation or refusing anticoagulation despite adequate information and physician advice. And these patients were the candidates that were thought to be ideal for LAA occlusion. And so this becomes a very involved slide, but I think it takes into account some of the important considerations that need to be taken with these patients. What's a very important point is that this is a preventive strategy. We are trying to prevent stroke. So our job is to try to decrease the risk of any adverse event that happens. And adverse events happen on the bleeding side for anticoagulants, but they also can happen on the device side with tamponade, with vascular access issues, and so on and so forth. And so this becomes a very nuanced conversation that requires a bit of time. And so this is something that has sort of organically developed, but is something that will be important as time goes on, as left atrial appendage occlusion becomes more widespread and more involved for our patients. And I'll be interested to see what the audience has to say as far as the different times when they would consider left atrial appendage occlusion in their practice. So future directions. Number one, pre-procedural imaging. Currently it's transesophageal echocardiogram. In the future is CT, ICE, and 3D printing. Number two, device design. Always the devices can be improved. And so number one, smaller sheets, more flexible devices can also be brought forward. And this is the companies are actively working on this, decreasing thrombus risk, trying to fit more anatomies. I think that's also something that even newer generations of the same devices are actively moving towards that regard. Post-procedural follow-up currently is transesophageal echocardiogram, but can CT be used for this is a very active area of investigation. Anticoagulation strategies, can these patients be done with aspirin and Plavix? Can they be done with Warfarin if they were on Warfarin? Should they be done on one or the other? How about one of these direct thrombin inhibitors or 10A inhibitors? Can those be used post-procedure, especially if the patient does not want to switch from using one of those prior to now using a Warfarin afterward and then having to do INRs or using two medications such as aspirin and Plavix and so on and so forth? How does this move forward? In addition, the indications are also going to be further evaluated. We already talked about contraindicated for anticoagulation versus being indicated for anticoagulation and what that means. Comparing this against these other oral anticoagulants is another thing that may come forward in either randomized controlled trials or in large registries. In addition, larger registry data is coming forward. So for example, the Evolution registry with the Watchman device. And another thing that's also coming as future directions is that just like the VARC definitions for valve data is very important for us to be able to take a look at this and say, what exactly is a bleed? What exactly is an MI? What exactly is a stroke? What exactly is procedural success? In addition, the same thing is also being undergone for left atrial appendage closure in terms of making a systemic, in terms of making an overall consensus definition document for the outcomes and the definitions of each individual endpoint. And so those are the future directions that are sort of that I can see is coming up in 2016 and beyond, as well as a few others that could not make the list right now. And for more information about all of these and any of this, you only have a few days left, but if you are in the area or have the time, one interesting and very impressive conference that I'm very honored to be a part of is the LAA conference in Frankfurt, Germany, that will be taking place this Friday and Saturday. So if you have an interest in LAA occlusion, then you are in the area able to come. This will give a hands-on approach as well as also go over the data, and it'll be a very lively discussion among worldwide experts. Thank you very much.
Well, that's fantastic. Well, hopefully some of our audience will be able to join you at the conference the weekend. That's great. And thank you so much for the fascinating presentation of what's a very sort of complex and changeable area. We have had a few questions from our audience. If I can dive into those now, Dr. Gafoor. The first one is, how do the new NOACs compare with Warfarin and LAA closure devices?
Sure, that's an excellent question. So the question was, how do the new oral anticoagulants compare to Warfarin and also to left atrial appendage occlusion? The interesting thing is that compared to Warfarin, they all do very well. They all seem to decrease the bleeding amount, which I think is good. In some cases have decreased also the stroke, in many cases have decreased also the stroke risk as well. However, compared to left atrial appendage occlusion, very little is known. We have no randomized controlled trial data at this time. Registry data is being developed, and people are even still figuring out after a device has been placed whether a new oral anticoagulant can be used as part of the anticoagulation strategy. So when it comes time to really decide whether new oral anticoagulation versus LAA occlusion, I think the big thing to sort of take back is the graph from the Eurointervention 2014 article, which really looks at how to then decide between new oral anticoagulation versus left atrial appendage occlusion. And this is, at this point, really a position paper and a thought process from some experts within the field. And it's not a mantra to say this is what dogma is and should always be in the future. This is an evolving discussion. I think we'll learn much more in 2016 and beyond.
Okay, well, that's a good conclusion. A question related to that, which we've had in, is what's the ideal device?
Sure. An ideal device is still a very important point that's sort of being developed over time. I think, we have the ideal endocardial device, we have the ideal epicardial device. I think each one comes with its own approaches. If I had to pick the ideal endocardial device, what would I want? I would want something that is the smallest frame size access possible that I could have, number one. Number two, I would want something that is something where I could puncture without the septum, and right now it's in an inferior and posterior segment, but it would be someplace where one sheath would really fit kind of the ostia, would really allow us to reach the ostium of any different left atrial appendage, number two. Number three, I would want a device that would allow us to be able to implant in any appendage and not have any limitations as far as depth. I would want it to also have a very low risk of thrombus. I would want it to be able to have a very low risk of leak and therefore cover all lobes. I would want it to also be able to fix in place, so that would mean the fixation has to be set up in such a way that it has a very low risk of embolization. And also, I think that the device should be very well seen on echocardiography as well as also seen on fluoroscopy. I think that to me is the ideal device. What the ideal patient device is, I think, is in addition to kind of all this, is whichever device allows them to be off of anticoagulation reliably, faster, and sooner. And so that is for me, from an implanter standpoint, that's what I think of an ideal endocardial device. That's what the patient thinks of an ideal endocardial device. As far as from an epicardial device, for example, a Santoheart and so on, what's important there is that we need to find a way to really approach the pericardium in such a fashion or approach the left atrial appendage epicardially without any risk of any negative outcome. And so, like I said, these are preventive strategies for stroke. And so really telling patients that they have to face an upfront cost of this % access complication is really a tough sell. And so right now, with the new modifications for Santoheart, I think that they are themselves in a better position than where they were before this. And I think there is hope for this. But in addition to this, I would want, if I had to pick a perfect or ideal device, I would want something where it can ideally be very maneuverable and come over the left atrial appendage without the need for any transeptal access and approach, and be able to sit in place and cinch down, and for us to be able to monitor this by TEE, or even if we wanted to monitor this by fluoroscopy, by just injecting into the left atrial appendage and then move in that direction. In addition, the ideal device, I think, if we can, from a technical standpoint, if we can move to a point where we could do this reliably with intracardiac echocardiography, and that would decrease the need in many centers to do this without general anesthesia. At the Cardiovascular Center of Frankfurt, we're doing our left atrial appendage procedures with TEE without general anesthesia. Then that's something from an ideal technical approach I think needs to occur much more often for this to be a more widely uptaken technology.
So it sounds like there's an awful lot of options out there, and things are progressing all the time, which is encouraging. And I guess decisions have to be made in conjunction with the patients for the optimal outcome.
Correct. I think the if I had to, looking at this chart, that's kind of where I'm sitting in terms of how I evaluate a patient and what's going on. When I take a patient in and see them as an evaluation for left atrial appendage occlusion, I think it's important to take a very good history. So in addition to how many strokes have they had, how many bleeding events that they have, how often are they taking their medications, well, how many times have they had this, have they had to stop their medications for A, B, or C reason, how many times have, and then I usually try to see if there's anyone else that is coming with them, how often are they taking this, what sort of other bleeding events do they have. For many people, it's often listed as nuisance bleeding, such as superficial eye bleed, or also a nick while shaving or something like that. But for the patient, these nuisances are a big deal. Trying to come into an interview, for example, while having a cut that just won't stop bleeding is a very, very traumatic experience, and that was one of the patients that we had. In addition to that, a lot of times these patients come in and just have a history of easy bruising, and they remember the day that they started Warfarin, they started their anticoagulant, because that was the last day that they had clear skin. And so while these are sort of taken in jest because these are not life-threatening issues, at the same time, this is something that, from a patient, is a very important issue. And so we put this together with the HAS-BLED score. We put this together with other risks of bleeding, such as thrombocytopenia, cancer, or risk of tumor. And then we talk to the patient about the whole procedure and what it entails. It's important for them to know that they will need to be on some anticoagulation afterward, for example, aspirin and Plavix in this case, or in the case of the U.S., where the Warfarin is still recommended. So that anticoagulation still needs to take place. Sometimes what happens is that the patient shows up in office having stopped anticoagulation due to bleeds or due to their just unwillingness to take it, and for them having to then restart that conversation to say, well, actually, you do need to be on some level of anticoagulation after this for a short period of time, and then convincing the patient that this is part of the kind of the overall picture when you look at this in terms of the long-term outcome at 45 days or at 6 months of over 90, 95% of patients that are able to be off of anticoagulation. If these patients are coming in with prior GI bleeds or intracranial bleeds, for example, what's important for us to be able to note is to talk with the gastroenterologist, to talk with the neurologist and say, we do have to put anticoagulation for a certain time period afterward, or this is what our thought process is. How appropriate, how okay is this for this patient? And sometimes for a gastroenterologist, that may require a second, a scope at a different time period. It may require initiation of proton pump inhibitor. It may require some further evaluation, and so on and so forth. For a neurologist, it may require repeat imaging. It may require a repeat evaluation. It may also require close coordination to evaluate symptoms and so on. So this becomes then a very multidisciplinary approach as this moves forward. In addition to this, I think it's important to also think about the strategy of patients who do have atrial fibrillation, and this is a management of patients with atrial fibrillation purely for their stroke risk. There are patients that will benefit from AFib ablation, and so which are those correct patients for that? I think that's the take-home. That's really important to involve the electrophysiologists to try to figure out what direction to go forward. When the conversations with the electrophysiologists I've had at the institution where I'm at, for example, a symptomatic patient with atrial fibrillation, one that feels that every time they go into it, that's, for example, paroxysmal, this is a patient that may benefit from an ablation-first strategy. However, there are patients that are also permanent, that have atriums in the 5 or 6 range, that have already gone through a cardioversion, or these are patients that are, or who are also asymptomatic. These are more risk factors that are leaning towards less likely to have a successful AFib ablation. In addition, there's also data that has been done from an Australian group looking at adequacy of AFib ablation in patients that have been done with prior Watchman, and they have been shown that this does, these patients do very well. Another point that's important to note is sometimes after an AFib ablation, especially if the CHA2DS2-VASc score is high, the patient may still require anticoagulation. So at that point, the AFib ablation was done purely for symptomatic control and potentially to decrease the AFib burden. However, there still is electrical mechanical dissociation, and these patients may still require some level of anticoagulation. Those patients could also be candidates for anticoagulation at that standpoint. So it becomes a very involved discussion. Another interesting trial that's coming forward is the AMAZE trial with the Sonderhart Lariat device. So this epicardial LAA ligation pathway has been shown, according to DJ Laccaretti and a few others, that this can potentially decrease the AFib burden by decreasing onitis or formation of abnormal electrical foci in the left atrial appendage. Therefore, the plan is for this AMAZE trial to try to ligate the LAA prior to AFib ablation and randomize patients with LAA ligation pre and then without, and then see what happens in terms of outcome for these patients. I think this will become a very interesting study for us going forward, because then this could potentially tip the pathway in terms of how and when the patients have their LAA treated, and in which patients the appropriate strategy, even if they are persistent, even if they are paroxysmal symptomatic patients, whether they may benefit from LAA ligation if this can be done in a safe manner prior to their ablation procedure. And that, I think, is a very important pathway for the electrophysiologist to be able to help us figure out.
Sure. Well, it'll certainly be interesting to see the results of the trial, and hopefully further progression will be made. But thank you so much, Dr. Gafoor, for answering the viewers' questions. It's been a pleasure having you with us today, so thank you for joining us.
Thank you so very much for involving me in this presentation. I am very happy to have these amazing questions. Left atrial appendage is going to be a very exciting field, not only in 2015 but beyond, and I look forward to seeing the results of not only the trials but also the real-world experience from everyone in the audience. Thank you.
Fantastic. Thanks so much. So that was Dr. Samir Gafoor speaking to us from Seattle today, and you can find out more about Dr. Gafoor in the link under this video. So it just remains for me to say thank you, the audience, for joining us today, and I'd be extremely grateful if you could rate this webinar using the star rating system on your screens. And just a note to say that if you want to listen to other webinars in our series, you can turn to the Academy section on our website, which is radcliffecardiology.com/academy/webinars. And be sure to join us for next month's webinar on the diagnosis and treatment of microvascular angina, presented by Professor Carlos Kasky. And you can find out more about this on our webinar page as well. So wishing you all an excellent rest of the day. Thank you, and goodbye from Radcliffe Cardiology.